Hey guys, this is Miss Fugit, and I'm going to start the narration for our topic, which is depressive disorders. And as you'll see here on the first slide, the depressive disorders covers all the topics for Thursday the 11th, including depression, suicide, and bipolar. I put them all together in one presentation, but they are broken up in different chapters, and those are the chapters listed below here. Chapter 25 and 15, and chapter 26 and 14, and the smaller number chapters 15 and 14 are the pharmacology chapters that go with them. Again, follow what is on the slides, hit the highlights on the pharmacology, know the most important aspects of it, and don't dive too awful deep. Alrighty, here we go. So on the topic of depression, when depression becomes a diagnosis, it's different than just a normal feeling of sadness. So everyone feels sadness from time to time, and that's appropriate, especially when there's a loss, such as a death of a loved one, maybe a pet, especially in children. When there's a significant loss, say of business or bankruptcy or divorce. And those feelings of sadness are normal when they're short-lived and they don't interfere with functioning, everyday functioning. Depression as a diagnosis, from a medical nursing terminology standpoint, is when the mood causes distress or impairment. And that's what you'll see a lot in our diagnoses is when they become a problem, they impair our activity, impair our ability to function. So with depression, it's an impaired social or occupational function. Sometimes the person who is clinically depressed is unable to function in society, hold a job, and do the normal things that would allow them to function in our society. Common features of depressive disorder include sadness, feeling empty, an irritable mood, somatic and cognitive changes, and the ability to function significantly are impacted by all of these things. 8 major types of depressive disorders are listed in your book, but we're really just going to focus on the top 4 most common types. Those include major depressive disorder, disruptive mood dysregulation disorder, persistent depressive disorder or dysthymia, and premenstrual dysphoric disorder. Major depressive disorder is characterized by one or more major depressive episodes where the depressed mood or loss of interest lasts at least 2 weeks. So this is a long-term constant depressive mood or severe loss of interest. Plus, in addition, you have to have 4 of these things. So you have your mood that's depressed, sad, helpless, discouraged, they're down. Loss of interest, pleasure, feeling blah, having no feelings at all, feeling like they just don't care about anything. There's social withdrawal can be seen in major depressive disorder. There can be physical symptoms, and those are the somatic disorder characteristics. They include insomnia, not being able to sleep, or sleep disturbances. Fatigue, that is more than just kind of feeling tired. It's a fatigue that's actually physically felt. Agitation, or even like a psychomotor retardation. Recurrent episodes also can equal weight gain and can create suicidal ideations. It's seen a little bit differently though in children. Children and adolescents don't have all of the words and the skills to show their major depression in ways that adults do. So you're going to see in children and adults, maybe that child is irritable in a different way. Maybe they cry a lot. Maybe they're cranky. That's different than you're going to see in an adult who may just be able to tell you they feel fatigue. They'll be able to tell you that they aren't sleeping. the child or the adolescent may not be able to verbalize these other feelings. And the treatment for major depressive disorder includes therapy and medication. Disruptive mood dysregulation disorder. In children and adults, typically it's seen between 6 and 18 years old. A lot of times it's diagnosed before they're 10. So this is something that is seen pretty early on, not like toddlerhood, but 10 is pretty young for this to be diagnosed. They are severely, chronically irritable with an angry mood. They have a low frustration tolerance. And this is seen with family, peer, and school disruptions. So these are going to be your kiddos that this does not come and go. Again, this is for 2 weeks or longer in a 10-year-old that is severely, chronically irritable and extremely angry. They are extremely frustrated easily, and they're going to act out on this. And it's typically tied to some kind of event in their life. Signs and symptoms that you can see in children and adolescents with this are going to be verbal rages, physical aggression, beyond the point of just siblings, arguing or maybe getting in a little bit of a fight or fighting at school. It's going to be really more pronounced, and you can have both also, because remember, these kiddos don't know how to express themselves. And treatment for this is going to be some family therapy. With persistent depressive disorder, there are 3 types of this. And this is really something that's seen. The reason it's called persistent is because it's an extremely long period of time, at least 2 years. With major depressive disorder, the characteristic is a minimum of 2 weeks. With persistent depressive disorder, it goes beyond just a major depression. This major depression lasts for years. And people kind of talk about, oh, well, that's how they've always been. That's how they are. That's who they are. Well, just because that's someone's mood doesn't mean that they still don't have some kind of major disorder. So in persistent disorder, they can be chronically depressed with mild severity. And this is what's called dysthymia. They're kind of blue. They're kind of they're a Debbie Downer. They're kind of just not happy, but it's not severe. They can have, though, major depressive episodes where they get worse. It can be continuous or intermittent with an incomplete recovery period in between. So this is always how they are. They're 2 years into their depressive disorder or longer, but then sometimes it really seems to get worse. It's going to wax and wane and kind of come and go. But it is possible to be in a major depressive episode for longer than 2 weeks, and when it really stretches out for a long time, that's when some severe intervention really needs to take place. Major depressive episodes with dysthymia is a double depression, right? So again, intervention is crucial. With premenstrual dysphoric disorder, this is seen in females. Males don't have menstrual cycles, so this is only for females. And it's something that's more than just a little bit of PMS. It really is a mood disorder where there's a severe change in behavior. And this is seen by severe mood swings, a lot of anger, high anxiety, severe fatigue, appetite changes, feeling really overwhelmed. Physical symptoms, there can be a lot of breast tenderness, there can be breast pain and weight gain. They can show signs of irritability, dysphoria, lethargy, sleep disturbances, difficulty concentrating, feeling out of control. Along with the breast tenderness, there's that breast swelling. and then they can have a sensation of feeling of bloating, and actually weight gain goes along with all of that. So there are physical symptoms and mood symptoms, emotional symptoms, and it really is more than just a little out of sorts. It's something that really impacts the ability to function in daily life. So here's a little exercise for you guys to do, and you can figure out which answer goes with which depression. So kind of work through that, and if you have any questions about what the answers are, you can use your book. It's not a test, but you might try to do that without it and see how many you get right, and then look those up in the book. If you have any questions specifically, we can go over this in class on Monday. So some information for you guys about adult depression, not childhood, but adult depression. Average age of someone with depression is the mid to late 20s, but it can occur at any age. 80% of people who have an episode of major depression have recurrent episodes. There can be a manic phase within depression, and during this manic phase, in manic phase, it comes with a greater risk from a low income group. So you're going to see highs and lows. That's that kind of up and down pattern that you can see. And there tends to be a family history of the manic phase. There can also be a family history of the depression, but also manic can run in families as well. And is it biological? Is it social? Is it learned? Yeah, probably a little of both of all of that. Studies have shown, this is just a little interesting fact, that the maternal mental health, depression in pregnancy can lead to a lower IQ in children. So maternal mental health is important not only for the mother but for the baby as well. And they're not sure if that's a genetic thing, or if maybe because she's depressed, maybe she's not eating right, or she's doing things that aren't as healthy for the baby. But it is an interesting fact. So we're going to talk about cultural differences in how depression is expressed and treated. Again, these are generalities, and by no means am I trying to stereotype someone. But what you'll probably see in the Hispanic, Latino, and Mediterranean cultures is more complaints of nervousness, headaches, and stomach aches. They're not going to come out typically and just say, I feel depressed. They might just be a little off. They feel nervous, having some headaches and stomach aches with that. In the Asian culture, they might talk about being out of balance, feeling weak, or feeling nervous. Native Americans and Asian Americans may utilize withdrawal. Sometimes they're trying to meditate and see if that can help. This talks about growth to treat. I'm not sure what that talks about. Again, I'm not going to test you on that, but you can see that probably in your chapter. See what that's all about. So objective signs of depression, you're going to see some psychomotor agitation. Maybe the patient's pacing, wringing their hands. Maybe they can't sit still. You could see psychomotor retardation. Maybe a slowed, soft, paused speech. They're choosing their words, or they can't get to what they're trying to say. Maybe they're having a slower movement or some slumped posture. You can see a negligence of personal hygiene, an apathy, or they feel, kind of apathetic, a lack of feeling, emotion, or energy. Change in eating and sleeping patterns, poor social skills or becoming withdrawn, and some altered thought processes. Just realize, though, that there's a difference in the level that you're going to see with depressed patients versus the schizophrenic patient, right? So your schizophrenic patient, you can see on the end of the spectrum, that catatonic, unable to move, versus someone with major depression. Maybe they don't get out of bed because they just feel hopeless. So you kind of have to ask more questions, put all of the pieces together to form your pattern before you can understand which diagnosis you would want to reach. So some subjective symptoms that you could see with major depression is in their affect, right? And what is an affect? So if you don't know what their affect is, look up that definition. I think that is on page 272 in your book. That affect may vacillate between sadness and apathy, so it can kind of wax and wane a little bit. They can feel numb. They may have feelings of guilt, anxiety, and worthlessness. Additional subjective symptoms include cognitive changes. So they can just kind of feel ambivalent. Again, if you're not sure what that means, look that up. They can have some indecision, inability to concentrate, memory issues, and self-blame, self-destructive thoughts of death and dying, right? There's that suicide. Maybe it would be better if I just ended it all. Loss of interest. Nothing makes them happy. Loss of motivation, confusion, pessimism, right? Glass half empty. Self-deprecation. So they're going to talk poorly about themselves, and they really mean it. This is not the self-deprecation when you're trying to elicit somebody to say something nice to you. When someone is severely depressed, they really, really at that moment feel that way about themselves. And then they can have some uncertainty. Further subjective symptoms can be physical. They can feel abdominal pain, chest pain, they can be dizzy, have headaches, insomnia, nausea, vomiting, preoccupation with their bodily functions, anorexia, constipation, fatigue, indigestion, changes in their menstrual cycle, and some sexual dysfunction as well. If you look on page 275, there's two different types of delusions talked about there. So kind of look those up, and then the definition of hallucinations. Remember, though, the hallucinations and most of the symptoms that are going to be seen in someone with major depression are not going to be on the scale that they are for the schizophrenic patient. These delusions and hallucinations of the depressed patient may come from lack of proper nutrition, lack of sleep. They're not, they will probably go away, right? Again, the patient with schizophrenia may have delusions and hallucinations for a lifetime. So some theories behind depression. One of the theories is biological, that there's a biological component to major depression. Could be related to the neurochemicals in the brain, and the neurotransmitters specifically associated and known to be related to severe depression are norepinephrine and serotonin. So knowing that, then that would make you think, well, what are my medications that my patient can take to affect their norepinephrine and their serotonin? And we will get to that. Other possible neurotransmitters that could have an impact on depression include dopamine, acetylcholine, and GABA. Other theories include there could be a genetic component to that. We do see severe depression running in families, so possibly there could be a genetic component. Could be due to endocrine dysfunction. So the hypothalamic pituitary adrenal axis, again, I'm not going to test you on that specific, but just know that people who do have endocrine dysfunction So if you have a patient with a pituitary tumor, then that could theoretically be one of the factors causing them to have major depression. So you always do have to, rule out some medical reason when you're trying to find a treatment plan. And then the circadian rhythm, it's their sleep-wake disturbances. People on night shift or people who, don't have their circadian rhythms right can have some depression. You definitely have, we've definitely seen this in people who have been tortured. Sleep deprivation is a form of torture, and it can definitely lead to some psychological issues. And then there can be some changes in brain anatomy, maybe due to injury or substance abuse or whatever, that can lead to some changes in the brain that cause depression. And this is why you're going to see some physical as well as psychological changes, which are expressed as depression. In addition to the biological theories, there's some psychological theories that have been put out there for reasons for major depression. There's a psychoanalytic theory that was presented by Freud. This focuses on important loss in a person's life, early in their life, in childhood, and we all know how childhood trauma can impact humans throughout their growth and development in the lifespan. There's the cognitive theory that states perception that all stressors are negative. The perception that all stressors are negative. If you always see stress as a negative and you never see the positive outcomes of it, then you're going to have a really tough time in life and have that view that life may not be worth living, because what's the point? Because it's ultimately unsatisfactory. So that's how you perceive in your cognitive theory. That's the thought. There's the interpersonal theory that states that people who have difficulty dealing with interpersonal stresses, again, interpersonal, right? But we know that is seen throughout many of our disorders. Behavioral theory is feelings of hopelessness and unworthiness lead to your overall general life attitude. I'm probably not going to test you on this, but it is good to know that there are multiple theories on why people become majorly depressed, and the major one was the psychoanalytic from Freud, and there are some others as well. Within these theories are three general themes, and we're going to see this throughout all of the disorders that we're going to discuss in this course. Underlying theme of a lot of them are, number one, a debilitating early life experience, right? Some major adverse childhood event, childhood conflict, childhood trauma, that the child was not able to cope with in a positive way, have positive coping mechanisms, somehow came out with a psychological disorder. Not everyone who experiences childhood trauma has a psychological disorder, but the inverse is a lot of people with psychological disorders have had severe childhood traumas. Okay, there's the intrapsychic conflict where they may have mixed emotions, right? This could be that child who is sexually abused by a family member. So you have love for that person, but you also have hate for that person. Those mixed emotions, especially in a child, you don't know how to handle that, and so until you work through it, that can be expressed as major depression. And then reactions to life events. We see that theme throughout, where there's that key that kind of jump starts things, it turns it on, and a lot of times this is some form of severe stress or severely perceived stress that is beyond what is normal or acceptable. So those are the general themes that we're going to see in depression, as well as some of our other disorders. So this slide shows you the difference between grief and depression. Grief is a natural response, whereas a diagnosis of clinical depression is seen as an illness. Grief is typically self-limiting. It surrounds an event, it gets better, and people work through grief. They can work through grief different ways and at different speeds, but it's typically self-limiting. Major depression is persistent. Grief doesn't improve with time, but major depression tends to worsen over time. Grief is responsive to social contact. Typically, your support system, family, friends can help you through your time of grief, but someone with severe depression feels burdened by social contact. Someone with grief usually can take medication if they need to for a short period of time, and then they find that they may not need that medication anymore. However, people with major depression can be on antidepressants for a long period of time, and if they're responsive to the medications, then that's helping them. It's not necessarily something that you can stop and the depression goes away. Typically, you're on that medication for a long period of time. So, risk factors for developing dysfunctional grief, and we're talking about beyond 6 months. The dysfunctional grief that turns into a depressive disorder. So those risk factors include a history of a psychiatric disorder. So if you are already diagnosed with schizophrenia, that's going to predispose you to possibly developing a major depressive disorder, because you can't deal with the stresses of life as it is, and then those normal stresses turn into a major loss, and your inability to have positive coping mechanisms is going to lead to that major depression. If someone is ambivalent, overly close, or has an intense relationship with the deceased, that can lead to dysfunctional grief. History of multiple recent losses. So someone whose entire family was killed in a car accident, that grief is just compounded. Also, if they were injured themselves, so that's grieving for themselves, grieving for their family, grieving for multiple losses, kind of compounds the grief. Loss of parent or significant other during childhood. You see a lot of people who've lost parents that have some major psychological disorders later in life or have some struggles. Also, if there's a lack of social support, and if the death is due to suicide, AIDS, we've seen some major depression with the survivors of people who've died, family members, friends, loved ones, partners who've died from AIDS. If the death was due to a murder or otherwise unexpected, it's still death, and there's still sadness when someone's older and dies, and maybe from a long, prolonged illness. But you can kind of understand how you can prepare for that a little bit more than if there's an unexpected suicide and there's guilt or blame involved, especially if there's self-guilt or self-blame. Then you can see some dysfunctional grief of the survivors with that. So as a nurse, what do you do if you're trying to assess someone for depression? And here in this slide, instead of the ADPIE, I put APPIE. maybe it's not a diagnosis, it's what you perceive, and that's just kind of some of the wording that you might hear throughout our nursing program or that you might see in the book. So our assessment of depression begins with asking the questions of the client to assess how long they've been feeling like this, right? Is it a day? Is it 2 weeks? Is it 2 years? Which symptoms are they having? How severe are they? How are they impacting their daily life? Are they physical symptoms? Are they behavioral symptoms? What parts of your life have been impacted, and how severe are they? Is there substance or alcohol or medication use or abuse? Are there any comorbid psychiatric conditions that we need to think about? Are there comorbid medical conditions? Again, so that patient who has type 1 diabetes but they can't get out of bed because of their depression, are they not eating? Are they not taking their insulin? How's their sugar doing? And then what are their interpersonal and coping skills? What are their level of stressors? And are they having any suicidal ideations? So when you're doing your assessment, you might have some different questions for the older adult. You're definitely going to have different questions for the child, and we're going to include the family member. But on the other spectrum, the older adult, we can see the prevalence of major depressive disorder declining with age, but the signs and symptoms may increase. So what does that mean? Well, as you get older, you may not have major depression, but if you do have depression, you may have more signs and symptoms of it. They can overlap, and sometimes it makes it difficult to assess in an older patient because they may overlap with some physical illnesses that they have. Do they have dementia as well as depression? Do they have Alzheimer's in early stage and now they have depression? What medications are they taking? Are they taking their medications? Clients are often diagnosed with dementia, and it can be the wrong diagnosis because it's actually depression that they have, and they don't have dementia. So, asking the right questions, talking to the family members, taking a thorough history is really, really important, especially in the older adult, and especially if the older adult is forgetful. Not all older adults are, so don't, again, not stereotyping anyone over a certain age, but just things to think about. Again, you can have dementia and depression at the same time, and major depressive disorders, and as well as just regular depression, are seen in early Alzheimer's disease. When an older person maybe has Alzheimer's, they understand the prognosis and they become depressed. You can actually see an increased risk, not just in Alzheimer's patients, but when there's multiple diagnoses and they're older in age, there is an increased risk in that age population, increased risk for suicide. So there's different ways to get to an actual diagnosis of depression. There are non-biological measures, which might be just a standard verbal or written scale. There's a lot of tools out there that medical providers, nurse practitioners, nurses can use, depression scales, either self-administered by the patient where they answer themselves, or taking that health history using a tool for a depression scale. You always have to make sure that you take into consideration cultural considerations and then the age of the client. There's biological methods. You can test someone's cortisol levels. That's the dexamethasone suppression test. In children, they do growth hormone assessment, because maybe if they're lacking in growth hormones, maybe that is a biological reason why they can be having some depression. And then we know that sleep, again, causes some major depression. So you might have some kind of sleep study, do a REM sleep analysis under and I'm not going to say this right, polysomnographic measurements. And that just measures REM sleep. Nursing interventions for major depressive diagnoses and disorders include psychotherapeutic management, psychopharmacological management, and milieu. So meds and milieu. During therapy, it's really important for the nurse to establish a relationship where the client is accepted as they are, where the client knows that they will be accepted, warts and all. The nurse-client relationship should be one where the client is valued as a human being, and we've talked about that already, but we need to make sure that the client knows that they're valued as a human being. And we do that through sincere and empathetic relationships, discussions, setting that tone for our therapy and our meetings, setting that environment. We like to point out small, visible accomplishments and strengths and build upon those. Even the smallest accomplishment to someone else may seem small, but when you're depressed and you can't even get out of bed, sometimes just saying, hey, you know what, today you got out of bed and you did that, and you couldn't do it yesterday, and tomorrow maybe you'll take a shower, and we're going to take this in baby steps. So really just kind of pointing out those accomplishments and building on them. We want to model interdependence rather than dependence. So we want to be their helper, but we're not going to do everything for them, right? We don't want them to become dependent upon us. Don't attempt to manipulate your client out of their depression. That's not a good way to get positive outcomes. Like we talked about with our schizophrenics, never argue with delusions, hallucinations, irrational beliefs, because to someone who's experiencing those, it is real. It is real to them. So we're going to use tact and empathy when we discuss what someone is seeing or hearing. We're going to handle any outbursts that they have through therapeutic communication. We're going to set those boundaries, what's allowed, what's not allowed, what's acceptable behavior. We're going to provide non-threatening one-on-one interaction with that depressed patient. This might be someone who we take for a walk, maybe around the unit. One-on-one, let's just go have a talk. Tell me how things are going. And then we're going to provide decision-making opportunities, but only those that the client can handle. So if a client is out of bed, that's great. We want to tell them how great it is, but then, maybe the next step, maybe they need to get dressed. We are not going to, if they have to get dressed because maybe they have to go to court, we're not going to let them go to court naked. So the decision maybe that we have them make is, you got out of bed, we know you have to go to court or you have to go to therapy. Which of these dresses would you like to wear? Which of these pair of shoes would you like to wear? Do you want to wear the blue socks or the yellow socks today? So sometimes it's almost like you would give a toddler choices, because it helps them become dependent in their decision making. But we're not going to treat them like a toddler, right? Unless they are a toddler, but that's a whole different thing. Adults, we want to treat like adults, but we need to give them decision-making opportunities that they can handle. So the pharmacological management or the medications is covered in Chapter 15, and that's for depressive disorders. You might just kind of breeze through that. correlate that with the slides. But the goal of these medications is to help alleviate the symptoms. We want to try to restore a normal mood, prevent recurrence of the depression, so they're going to be on it for a long period of time once they get stabilized, and we want to prevent a swing into mania for our bipolar clients. The primary antidepressant classes that we're going to focus on are found in box 15.2. These include the cyclic or reuptake inhibitors. They're the SSRIs, SNRIs, NDRIs, your TCAs. Again, look in the book, look at the box. I'm abbreviating here. And then there's some new antidepressants that you might familiarize yourself with, or you may know them and already be familiar with them. There's also some enzyme inhibiting agents, and those would be our non-selective MAOIs and our selective MAOIs. So sometimes medications, when taken too much, or if a client is elderly and it builds up in their system, you can get toxicity from that. Our clients can become toxic. And with TCAs, signs of toxicity to their medications would show up as drowsiness, tachycardia, mydriasis. So look that up. Get your phone out and Google it. Hypotension, agitation, vomiting, confusion, fever, restlessness, sweating. There's more potential for adverse events with our TCAs. So we really, if that's the drug of choice for our client, we have to really be aware that TCAs have a high risk of toxicity. It's probably not going to be our first line of treatment, our go-to with our newly diagnosed patient, just because of the high risk of toxicity. With our MAOIs, signs of toxicity include dizziness, vertigo, and fatigue. So you can see that those aren't as severe as our tachycardia, vomiting, right? Those things with our TCAs are a little more severe. MAOIs, again, toxicity, dizziness, vertigo, and fatigue. And really our first line treatment is our SSRIs. There's a low probability of toxicity with those, and so that's why we kind of use those first. So our most toxic antidepressant are going to be our TCAs. I want you guys to look at the box 25.2, which are important nursing considerations for when you're going to administer antidepressant. Just know that antidepressants have a lag time, so you're not going to get an immediate full effect of an antidepressant right away. It takes about 2 to 4 weeks for that full effect of medication to kick in, and that's something that you need to make sure that you educate your client and the family on. They might provoke suicidal ideation or behaviors. Some of those can have that reaction. So if a client is already having suicidal ideations, we're going to be real choosy on which medication we're going to give them. It's always a question we're going to be asking, but especially if you're going to add in some of those antidepressants that can make those ideations worse. We're going to watch our patients for cheeking the medication or pocketing the meds, especially in our inpatient setting. So we don't want them to pocket them and then take them back and overdose, right? We want them to get the full effect, and we want them to be on our treatment plan, not their treatment plan. We always want to monitor the vital signs, especially with those TCAs, because risk for toxicity is there. TCAs can cause orthostatic hypotension, some reflex tachycardia, and arrhythmias. Then the MAOIs can trigger a hypertensive crisis. So see right there, where that you can see the difference. TCA is going to drop your blood pressure and raise your pulse, give you some funky heart rates. Our MAOIs, the crisis potential there is for high blood pressure. Those SSRIs often have sexual side effects, and it's for that reason that sometimes people don't want to take them or stop taking them. Maybe they're feeling better, the depression is better, they've entered into or returned to an intimate relationship, and those medications are impacting that and they want to stop it. So it's always good for those clients to have discussions with their provider before they just stop those. MAOIs can have drug-drug or food-drug interactions, and I think that's listed either in Chapter 25 or the correlating chapter previous on the drugs. So because of their low risk of toxicity and side effects, the SSRIs are usually our first line of treatment with major depression. They're widely used. They have few anticholinergic or cardiovascular sedative side effects. There is a black box warning, and that's the one for increased suicide. That's really our major issue with the SSRIs, especially in children, adolescents, and young adults. So we really kind of watch, we don't jump to antidepressants in our youngsters. We might try some different approaches first because of the increased risk for suicide. There's antidepressant apathy syndrome. Look that up. I don't think I'm testing you on it, but it is something that you can learn about. And then we never combine SSRIs with MAOIs because that combination can actually be fatal. Good to know. The SSRIs are absorbed in the GI tract. So if a patient has some kind of comorbid disease, they have Crohn's disease, they have some kind of absorption or malabsorption issue, just know that the SSRIs probably aren't going to work as well because they are absorbed in the GI tract. They have a long half-life, which means that we do daily dosing. It is metabolized in the liver, so if a client is elderly, they have liver problems, they have cirrhosis, then you're going to see some problems with the metabolism of these medications. There's a low potential for overdose with SSRIs. Again, we like these. It's our first line of treatment. Pregnancy category C, except for the paroxetine, which is a D. It is safe in older adults, but you do have to consider, their GI and their liver issues. So my slide still has the name Prozac on there. I think your slides that we gave you had Prozac taken away, but I'm just going to put this up here on Blackboard because I think you need to know both names. You will be tested on the generic name, and you will be, in my class as well as any other class in nursing school, any other teacher is going to give you generic names and test you on those as well as boards. So it's just good sound practice to know both. But the individual SSRI here, fluoxetine, is also known as Prozac. It was the original, it's the OG first SSRI developed. It's frequently still prescribed. It's very inexpensive. Providers can also often prescribe that for pain management and smoking cessation. So if you have someone and you're doing an admission assessment and you're doing their med rec, they may not be depressed. They may be on the fluoxetine for a separate issue such as pain management or smoking cessation. Fluoxetine has a long half-life, which really makes it ideal for those who forget to take their medications. It's going to stay in their system a little bit longer, and it's available also in a once-weekly formula. So individual SSRIs that you should be familiar with are citalopram, which is also Celexa, escitalopram, which is Lexapro, paroxetine, which is Paxil, and sertraline, which is Zoloft. Just good to know that those are in the category of an SSRI. So if you get a question that says, your which of these would the nurse expect to be given for their patient with depression, select all that apply. And if all of these were on there, you would select all of them. Okay. So our serotonin, norepinephrine reuptake inhibitors, our SNRIs, these are the things that are going to block the reuptake of our serotonin, norepinephrine. They have similar side effect profile like the SSRIs. They include duloxetine or Cymbalta, and this really has good side effect profile, no sedation or insomnia, but the downside is they have significant sexual dysfunction in patients who take this, and so if the patient is still sexually active, getting somebody to stay on this for a long period of time is probably not going to be very likely. The next one here is the Effexor or venlafaxine, as well as Pristiq or desvenlafaxine. These can cause increased blood pressure and nausea, but they have less sexual dysfunction seen, and they don't have a synergistic effect of if you take it with alcohol. We don't ever want our clients to be taking alcohol with their medication, but this does have a lower risk. And it has less sexual dysfunction, but you're going to see the increased blood pressure and possible nausea. So that's really kind of something that a provider might talk to their client and why they might choose one over the other. It's also something that, if it is prescribed by the provider, you as the nurse, if you know your client, you're having an education discussion about the medication, and they have some issues that might make a different choice, a better choice for that client, then you can definitely have that discussion with their provider and give your input. So another way that a provider might choose to attack depression is with an NDRI or a norepinephrine dopamine reuptake inhibitor. Okay, it does just what it says. These include our Wellbutrin, Zyban, Eplenzin, which is all of those are different trade names for bupropion. People also use bupropion a lot for smoking cessation. It inhibits the reuptake of dopamine, but it does not affect the serotonin level. It has a good side effect profile. It's a good replacement for an SSRI if those medications are causing sexual side effects and you're looking for an alternative. Maybe you want to add them together and you have an SSRI and you want to add something else in, or you have a patient that is taking an SSRI and would like to also take bupropion for smoking cessation, then these can be taken together. It's far less lethal. Okay, put a little star here. Remember, far less chance of being lethal than a combination of TCA and an MAOI. Ding, ding, ding. Circle that. Very important. And it is contraindicated, though, in people who have seizures. Some of the newer antidepressants include these listed here. Trade names are Remeron, Vibrid, Brintellix. The generic first one there, side effects might include some sedation and weight gain. With our Vibrid or the Vilazodone, you're going to have less sexual dysfunction. We see a lot of the Brintellix or the vortioxetine. used in our dementia patients because of the cognitive benefits that have been seen with that medication. And then there's always the tried and true trazodone. We have seen some providers using trazodone with our depressed patients who are having insomnia. So that's a good additive that you can add in, and trazodone has been found to be non-addictive. So our TCA tricyclic antidepressants block the reuptake of the neurotransmitters norepinephrine and serotonin both. They're slightly more effective than the SSRIs, but they do come at a cost, and that cost is more side effects and more serious side effects. Providers may choose to use them because they do have a side effect of sedation. So if a client is having insomnia, that might be something that we desire. You can see decreased lethargy, improved appetite, reduced anxiety, but especially in children, you can see some urinary hesitancy, childhood enuresis.
All right, let me get some stuff.
So these TCAs, when used, they're absorbed in the GI tract. We give them orally. They are metabolized in the liver, and they also have a long half-life, which allows for daily dosing. They're initiated first at a low dose because of their greater risk for toxicity and side effects. So we want to kind of start low and increase slowly over about 3 to 5 days, so we can see how our patient is going to tolerate this medication. And the effectiveness appears equal across the class, so not one TCA is really better than the other. So those side effects that you would see with clients taking a TCA, it can affect their peripheral nervous system, having an anticholinergic effect, and with that type of side effect, you're going to get dry mouth, blurred vision, some urinary retention. You can have some cardiac issues with the tachycardia, the arrhythmias. You can also, those can also lead to an MI. You can have an adrenergic effect and have some reflex tachycardia. Also, you can have some effects on the central nervous system, causing sedation, confusion, disorientation, delusions, agitation, anxiety, and nightmares. Suicide can be seen in patients who take TCAs because of the energized feeling that they feel because the way that it impacts them. And so now they actually have some energy, they have this agitation, and they've been having some suicidal ideations, and now they have the energy to act upon those thoughts. TCAs can have drug interactions, especially with our CNS depressant, because they themselves work on the central nervous system. So with our CNS depressants, if you take a TCA, you're going to get worsening of the central nervous system or more greater depression. If client is taking over-the-counter stimulants or the MAOIs, that's where we're going to see some severe reactions. What that's going to present itself is a patient with a very high fever, maybe having seizures, and you can have a hypertensive crisis that can become fatal. So really some, again, lethal drug-drug interactions with TCAs and MAOIs, or some stimulants if the patient is taking maybe a Vyvanse or an Adderall, or over-the-counter things like caffeine pills. Mixing that with TCAs is going to be some bad news. Also, antipsychotics, anti-Parkinsonian medications, and antihistamines, you can have an additive effect. You're already going to get the anticholinergic effect with your TCA, but then you add these other things and it's just going to compound. Nursing implications to think about in special populations who do use TCAs. The side effects and the interventions are covered on page 166. Toxicities, those interventions are covered on page 166. Use in pregnancy, it is not teratogenic, but we do avoid we try to avoid giving clients in their first trimester this medication. And then especially in older adults, we're going to start very low, go very, very slow, and we're going to really monitor these patients closely. So if you have a client who's been prescribed a TCA, nursing teaching should include the contraindications of additional medications. Those clients should be told, do not take additional CNS meds or MAOIs. Don't call them CNS meds, don't call them MAOIs. Be specific, use the trade names for your clients. We're probably going to handwrite that out or have some printouts with them so they remember what they should not be taking with these TCAs. They're going to get that information given to them again from the pharmacy, but additional continued teaching, because this is a lethal concoction. It's really the number one thing with your TCAs that you're going to teach our clients. Also, they need to know that it's going to take 2 to 4 weeks to get full therapeutic effect. So that would be a great test question, either by me or on NCLEX, asking about when you would see therapeutic effect of a TCA for someone with depression. We do want them to avoid stopping their TCAs abruptly because of the way that it impacts the brain and the central nervous system, the heart, and the peripheral nervous system. If they stop it abruptly, they're probably going to have some headaches, they're probably going to have nausea, they're going to have some malaise. So it's never good to stop abruptly. We tend to taper them down on these. They should report eye pain immediately to their provider, give you a call, especially patients with glaucoma, because there's some eye toxicity that can be seen. And some of their side effects when they first take the TCAs, the mild side effects, we want to let them know that some of those mild things are probably going to lessen over time. We need to know if they don't. We need to know if they get worse. We need to know if they start having the side effects of showing signs of toxicity. And I want you guys to be able to know the difference between normal side effects that are going to lessen over time and side effects which are going to show me that the patient is toxic. So write that down. That's something I want you guys to look in the book for. Individual TCAs include amitriptyline. This is very sedating, and it is also cardiotoxic, right? It's hard on your heart. So amitriptyline is really reserved for not first-line major depression. It's not something that we jump to because of these side effects. Desipramine is the most toxic TCA that's prescribed. It's an activating antidepressant. It is helpful with apathy, lethargy, or hypersomnia. So it kind of gives the patient wings, like the commercial says. Again, though, that can lead to, if they're already having suicidal ideation, maybe they now feel like they have the energy to carry that out. We use this very, very cautiously in children due to the cardiovascular side effects. Imipramine is the oldest TCA. It's very effective, but again, we use in children with caution. Nortriptyline is the least toxic TCA. It's used a lot in older adults. Next category of antidepressants we're going to talk about is our MAOIs. These are highly toxic. Okay, these are only used with our hospitalized clients because you really have to monitor them closely. It's not something that you're going to see typically someone on MAOI outside of an inpatient facility. They block the breakdown of monoamines or monoamines, depending on how you want to pronounce it. The biggest threat is they can lead to a side effect of life-threatening hypertension. So hypertensive crisis can be seen in MAOIs. Again, with all the antidepressants, there's a 2 to 4 week threshold before full therapeutic effect is seen. Just like the other antidepressants, MAOIs are absorbed in the GI tract. We give them orally. They're metabolized in the liver. No real great risk for older adults unless, just like everybody else, if they have GI problems already or liver problems, then we have to watch that. Side effects. CNS side effects can include agitation, acute anxiety attacks, restlessness, insomnia, euphoria. Cardiovascular side effects, here's that hypotension or hypertension. Hypertension can be a mild side effect, or it can really, really go the opposite direction and lead to heart failure. So you can have a hypertensive crisis and you can have a hypotensive crisis. Look in the book, understand the differences. Just know if you have a patient on an MAOI, you really got to monitor their vital signs. Anticholinergic effect, just like our TCAs, you can get the dry mouth, blurred vision, urinary hesitancy, constipation. There's a table on page 168, table 15.4 of the drug-drug interactions. Know the main ones. SSRI, MAOIs, you never combine the two because it can be fatal, right? CNS depressants and stimulants should not be taken with MAOIs. And then antihypertensive, anticholinergic, those should not be lumped on top of MAOIs because MAOIs are already giving you hypertensive problems and anticholinergic side effects. There's a food-drug interaction box on page 169, table 15.9. The main thing to know here with MAOIs is the tyramine. And tyramine-rich foods can cause negative effects in people taking the MAOIs. So tyramine is found in aged cheese, bananas, salami, sauerkraut, soy sauce, all beers on tap, and I don't know why on tap and not on bottle, but beer on tap, and coffee. So these would be patients who are taking MAOIs. MAOIs are going to be given inpatient, so hopefully we're not serving them beer on tap in the hospital, but coffee, soy sauce with their lunch, bananas, these are things that patients with MAOI should not be having on their diet. Nursing implications, excuse me, if a patient is overdosing on an MAOI, first thing you got to do is check their vital signs. Okay, what's their pulse? What's their blood pressure? Emesis or gastric lavage may be helpful to get any pieces of the pills out. If they're having a hypertensive crisis and they spike a high fever, we may need to use external cooling blankets, some type of whatever your facility uses to cool the patient. And then if they're hypotensive, then we've got to treat the hypotension, and we're going to do that with fluids. So if our patient in the facility is taking an MAOI and they start to have some side effects, your nursing interventions are going to be focused on what type of side effects they're having. So if they're having some CNS hyperstimulation, we need to reassure our client. yes, I understand what's happening, and we're here with you, and we're going to do all the things to help you feel better. We're going to assess them for psychosis, hypomania. Make sure if they've ever had a seizure before, we might place them in seizure precautions. We're going to hold any further medications, and we're going to notify their provider. If they're having some hypotension along with their MAOIs, again, we're going to monitor those vital signs. Check their blood pressure. Are they having postural hypotension? They're a fall risk, so we need to instill our fall precautions. And we might want to have them sit down or lie down depending on what their blood pressure is, depending on how severe their side effect is. If they're having some anticholinergic side effects, these are typical side effects that we might expect to see. And we want to reassure that client, yes, I understand that you're having some dry mouth. That is to be expected. We think that it will probably go away over the course of the time that you take the medication. This is not something that is a severe side effect that we would stop your medication for. So let's treat that dry mouth with maybe some lozenges, drinking water, those type of things. If they're having any hepatic or hematological symptoms, we're going to get some labs and check those and hold the med until we get some further orders. Some of the new approaches that we have seen lately for major depressive disorders include ketamine. Ketamine is something that's been used with the military, and now it's being used in the States. In the ERs, we're seeing it used a lot, and in the psychological community. Botulism toxins, some scopolamine patches, adjuvant antipsychotics, anti-inflammatories, vitamin D, and then the L-methylfolate supplementation. I will not test you on that. That's just kind of FYI for your practice. Principles for milieu management with a patient with major depressive disorder. The client with a negative self-view, we want to encourage them to participate in activities for some positive feedback and mastery. If they know how to play chess, maybe we sit down and have them teach us how to play chess. They're definitely going to have a greater mastery over me that doesn't even know anything. So, they don't have to win, but we can show small strengths that gives them some of those little wins to help their negative self-view. Maybe they need some assertiveness training. Maybe we get someone that comes in from the outside that does some of that or specializes in that. Encourage hygiene to avoid embarrassment. Your family. If you have that conversation with them, your family's coming in, and I know that you really want to see your daughter. Let's get you up and cleaned up and dressed and brush your hair. Let's change out of this gown you've been in for 2 weeks. So you look beautiful. For your daughter that's coming in. So we want to encourage that. And then for our withdrawn client, the role of the nurse here for anybody who's withdrawn, especially if they're withdrawn for depression, is we want to check on them quite a bit. We want to do frequent, brief little contacts that really limit their isolation. We don't have to stay in with them 24/7 and sit with them unless they're in a state that we need to do that. But we want them to know we're here, we're checking on you, we care about you, and that the behavior is not going to be deemed appropriate to be completely isolated. We may, if the client is out and all they want to do is go back to their room and they don't listen to us and follow our instructions, maybe when they come out, we lock the door behind them so they can't go in there, but we let them know the boundaries. We're going to lock this door while we go to therapy, and then after therapy, you can have 30 minutes back in your room for some alone time. So if we have a major depressive disorder, a client with that disorder, and they're not eating, we really want to encourage them to eat. We're not going to leave the tray with them in hopes that they might, of their own volition, eat. We may actually need to feed the client. And maybe it's not us, maybe it's our tech. But if we can also do some milieu therapy with them, maybe we're doing some assessments while we're feeding them. It doesn't just have to be focused on the food. It can also be focused on the interaction, the relationship that you're having with your client while you're feeding them. We want to allow them to have some choice in the foods that they like. A lot of times we allow family to bring some home foods in, if that's okay on their diet. We want to encourage small, frequent meals, especially if constipation is a problem. Maybe they don't eat 3 meals a day. Maybe they eat 6 small meals. We want to monitor their I&Os, and they may not have a bowel movement every day if they're only taking in a certain number of calories, but we want to always remember safety and security. So if it comes to the point where the discussion is had about feeding tubes and that kind of thing, that's where the ethical considerations come in. We're not going to really delve into that, but for the severely depressed client who's not eating, you kind of again have to take it by the situation and go forward from there. If the client has sleep disturbances, we want to record the amount of sleep that they're having, amount of sleep that they're reported to have, and then if they're inpatient, the actual amount of sleep that maybe people see them have. They may say, oh yeah, I'm getting plenty of sleep, but then the night shift says, no, they were up in the day room all day playing cards. So you would want to have a conversation with the client about that. We're going to want to discourage caffeine and daytime napping, or things that might disrupt their sleep even further. Somatic therapies, or therapies that are physical and physiological interventions, include electroconvulsive therapy. They use that probably more frequently than you realize, and it's not like One Flew Over the Cuckoo's Nest. Sometimes you have to have the discussion with the client to change their perception of what ECT is. It has a great success rate. It's not grotesque. It doesn't cause grand mal seizures. It really is a viable treatment, and sometimes it's the most effective treatment for severe depression. Additional things that are used are vagus nerve stimulators, phototherapy or bright light therapy. There's some magnetic stimulation that's been used. So there are some other options, usually in conjunction with medication and group therapy or individual therapies. ECT provides only a mild electric shock. There's a brief seizure that happens, but it's not a grand mal seizure. The patient is given anesthesia, so it's more like a conscious sedation that you might see in the ER if you have a client who comes in maybe with a hip or a joint out of place. They get mildly sedated to where they don't feel the pain and they don't remember the ECT. This really is safe for severe depression. There's 3 types of anesthesia meds that are typically used, and it's atropine, which is going to decrease their secretions and prevent aspirations, because really the point of ECT is to produce that mild seizure. They're going to use what's called methotrexate or Brevitol, and that is really an immediate anesthesia. And then we're going to use some SUX or some succinylcholine, which is a neuromuscular blocking agent. So different medications probably than we use for the conscious sedation in the ER, but kind of the same thought goes into why we do it. If you have the opportunity to see an ECT, I highly recommend it because it's not something that is widely talked about or discussed in regular nursing fields outside of psychiatric care. Generally, the nursing responsibilities would be the same as if you were monitoring a patient who had a seizure or someone who might have had some sedation. So it's the ABCs. Airway's the first thing. We're going to assist with any ventilation that may be needed. Maybe you do the chin thrust, maybe you lift the head and put it back on a pillow, maybe depending on the protocol of where you are, maybe they have an oral airway placed. I don't know. Second is B for breathing. They're going to be placed on 100% oxygen. We're monitoring their respiratory rate and their pulse ox. C for cardiac, they're going to be on a monitor, probably going to have an EEG as well, so we can monitor their vitals and their brain and seizure activity to make sure that we're hitting where we need to hit and doing what we need to do. After the procedure, you're going to treat them as if you would a normal seizure patient. We're going to reorient them. They're going to be groggy, confused, disoriented. You may, if they have some agitation after, you may have to administer a benzodiazepine to help treat that. Again, that's a maybe have to, and it would just be on your cart as a PRN. And then we're definitely going to document all aspects of the treatment. What was done, how long they had their seizure, what activity did we see, what was their vital signs, what was on the monitor, how they tolerated it, how they came out of it, and anything else that you need to add. So the pros of ECT include the potentially life-saving advantage that it has, because it provides the fastest relief for severe depression. It is safe, although anesthesia always does come with some risks. It is a safe and proven treatment method. It's more effective than antidepressant medication, and it's really safe for adolescents, older adults, and the elderly. The cons of ECT is that sometimes it provides only temporary relief. We're not sure. Everybody is different, so it might last one person longer than it lasts another person. If someone has had multiple episodes of receiving ECT over their life, they may react to it differently and have different time frames of relief of symptoms. It doesn't cure severe depression, but it sure does help with the symptoms. You may need to do it repeated times for full effect. There is the stigma surrounding it and the fear that patients often have. There is some memory loss associated with it, but it's not long-term memory loss. There's some physical risk, including cardiac, hypertension, arrhythmias, but it shows no signs of causing any brain damage. The other therapies are just kind of for your information. That's their definition, and I'm not going to test you over those. So just kind of FYI for your practice. Suicide is something, again, that we will talk about throughout most of the discussions we have regarding psychological disorders. It's influenced by cultural beliefs, by values and norms that people hold. It can be seen in children, adolescents, and adults. Major depression is not the only time when you see suicide, but it does occur quite a bit in people with major depression. People who are schizophrenic and alcoholic have an increased rate of depression. Those two together are a recipe for not great outcomes. And they're typically, suicide typically occurs within a period of despair. So something has caused them to have an increase in their symptoms. Risk factors for suicide. include most people are male, most are white or Native American, older than age 60 or older. We're really seeing more and more older white men attempting suicide. It does come from a feeling of hopelessness. There can be serious medical illness or serious pain that the client doesn't see a way out of. Severe anhedonia, living alone, prior attempts. We often do see people who've made multiple attempts at suicide. They can be facing unemployment or financial issues, history of trauma or abuse as a child, substance abuse, family history of suicide, social isolation, and access to the lethal means. The terminology when we talk about suicide includes suicidal ideation level, their thoughts, their gestures, their threats. So are they just having thoughts? Are they having thoughts and they've made an attempt? Are they having thoughts, they've made an attempt, they're threatening to do it again? You can see how that kind of goes up the level of severity. Gestures include self-injury acts like cutting or little minor overdoses or some quote-unquote accidental overdoses that may or may not have been accidental. You look for patterns. You look for patterns in behavior. You look for patterns when you're asking assessment questions to build the picture more fully. Suicidal threats are verbal statements of intent. They often precede the attempt. In the attempt, a suicide attempt is an act with the intention of ending one's own life. A suicidal risk assessment, when you're assessing someone for their degree of risk, is there a plan? The more developed the plan, the greater the risk. So if they know a date, they know a place, they know how they're going to do it, the more in-depth their plan is, they really put some thought into it. This is not just a passing notion for them. The method is important. The smaller amount of time between initiation of the plan and delivery of the plan, the greater the risk, right? So if their plan includes a gun, you're going to die a whole lot quicker than if their plan includes an aspirin overdose. You can save someone theoretically from an aspirin overdose. You cannot save someone when they put a gun, in their mouth. So it also includes availability, ease of access, and speed of action. A gun works a lot faster than an overdose of aspirin. And then rescue. Is there a deliberate deceit on their part to avoid any possible rescue? If they're going out alone to a place where nobody knows that they've ever been, if they get on a plane and they fly somewhere and they don't tell anybody, they mean business. It's not a veiled threat. If someone talks about it and they're threatening it in the heat of passion, and they want, and the risk of somebody saving them is greater, the risk of it actually going through is less. Hope that makes sense. Nursing interventions for the suicidal client. We want to develop a nurse-client relationship first and foremost that includes trust, understanding, open communication, and acceptance. We're assessing for suicidal thoughts, plans, access to means, and previous attempts. All those things together, compounded, add up to how great is the risk? What's the danger? Asking about suicide does not drive a client to the act. You asking if they're thinking about it is not going to put it in their head. If you ask someone who is not thinking about suicide, you're not going to plant that seed in their head. But oftentimes, if you ask someone who is contemplating suicide, they'll talk to you about it. The time that they won't talk to you about it or they deny it is, if they've already made up their mind and they know their plan and they've been thinking about it, and they're going to thwart any kind of opportunity for rescue. That's when it's the greatest danger. That's when your risk is the greatest. We want to assess these risk factors. We want to have close one-on-one observation with the client. So on NCLEX questions, you might see the nurse is caring for a client on a psychiatric unit. Which client should she see first? When you're trying to assess for who's at the greatest risk of whatever it is, risk for suicide, risk for post-op complications, risk for cardiac issues, you're going to count the number of risk factors, and the person with the most risk factors or the greatest risk factors wins. Also, NCLEX is going to throw you in some clues. It's going to say severe pain. So severe pain, you're going to see that person first before you're going to see someone with a mild headache, right? So that's how, if you've narrowed it down to two patients that you want to see and you want to see both of them, can you count up the number of risk factors, or are there any clues about severity that are going to lead you to know who you want to see first? When you're doing a discharge plan for a patient who has severe depression, we're going to, again, talk about recovery. We're going to talk about the uneven path of recovery. We're going to stress that they're going to see some ups and downs. This can also be for a patient who has had a suicide attempt or has some suicidal ideations in the past, and they're going to be now discharged home with some outpatient follow-up. Recovery is for all of those people. If the client gives consent, you can educate the family as well on signs and symptoms of risk factors that can increase their severity. Or I should say the severity is increasing if they're showing these signs and symptoms. But first you got to get the consent of the client if they're an adult and they have capacity. If the family sees that the client is having more sleep disturbances again, if they're having anxiety, agitation, they're getting more agitated, they're starting to talk about suicide or showing suicidal behaviors, right? Those are things that you want to educate the family on. But again, we're going to get the client's consent. We're going to document that consent given. If no consent was given, we're going to document that and CYA. So the family can't come back and say, why didn't you tell me? If I don't have consent and the patient has capacity or they're not incompetent, then I can't discuss with the family something that the patient doesn't give me permission to discuss. But we're definitely going to document that consent was requested and denied. We're going to document any education given on firearm safety, if they do have firearms present, and then we want to help them with follow-up therapy, give them a list of resources, make sure that they know what the outpatient plan is going to be. So with our bipolar patients, what you're going to see with them is severe manic episodes with periods of severe depression. That is what bipolar, right? Two poles, opposite directions, bipolar, up and down in a severe form. The manic episode, they're going to be highly elevated mood, expansive mood, very irritable mood, but it's going to be turned up to an 11. It's going to last a week or more. So, it's more than just, hey, I'm in a great mood. It's they are manic and they're in a manic episode for a week or more. It typically begins suddenly, it can escalate rapidly, and it can really last up to months. It impairs judgment. It impairs their social ability. They can abuse substances often. It's usually seen onset in the 20s. You have a grandiosity or an inflated self-view. They're all important. It impacts all aspects of their life. They have risky behaviors. Maybe they overspend. They go on spending sprees. They're highly sexual. They have affairs. They wear very loud clothing. They have excessive makeup. And they can relapse and become hospitalized frequently. Causes of mania, they think there's a psychiatric disorder, bipolar 1 disorder. There can also be medical conditions that cause mania, such as hyperthyroidism. It's been seen in AIDS patients, patients who've had a stroke or a brain tumor, or MS, muscular sclerosis, so things that impact the actual brain structure itself and chemistry. Can be seen as a side effect of medication. Antidepressants, steroids, anticholinergic stimulants, levodopa can cause mania. So there are different types of bipolar, and bipolar 1 disorder is very similar to schizophrenia. I want you to look at table 26.2, and that pertains to that. Mood swings between manic episodes and major depression. So you really kind of have to, in your assessment, if you're trying to figure out if someone is bipolar with mania or schizophrenic, those questions: how long has it happened? Are there ups and downs, peaks and valleys? How is that different from what you should expect to see in someone with schizophrenia? Diagnostic criteria. Manic episode is distinct and persistent, a week or more. They have 3 or more of these symptoms present. They might include grandiosity, decreased need for sleep, they're more talkative, flight of ideas or racing ideas, they're highly distracted, and they have risky behaviors. Marked social, occupational impairment or hospitalization, and it's not caused by a medical condition, or it's not a side effect of a substance, right? A true manic episode within bipolar is not caused by hyperthyroidism. So hyperthyroidism can cause a symptom of mania, but we can easily fix that, right? If someone's taking levodopa and they have a manic episode, stop the levodopa and your mania will stop. That's how you know. That's how you can rule other things out. Other bipolar disorders include bipolar 2. In this one, you're not going to see a manic episode. Okay, the manic episode is in bipolar 1. That's the classic. Bipolar 1 is the classic bipolar, up and down bipolar with mania. Bipolar 2 is not, doesn't have manic episodes. It's a major depression with hypomania, right? Hypomania means really, really the opposite of mania. So bipolar 2 is really a severe depression without mania. You can also have a cyclothymic disorder. It's where you have that really, really opposite of mania, the hypomania, and you have dysthymia. It's typically a smaller pendulum swing. They don't have the really, really highs and the really, really lows that you see with bipolar 1 with mania. But it tends to last longer. The dysthymia that we typically talk about is 2 or more years, right? This is who they are. So objective behavior of our bipolar patients would include speech pattern disturbances. such as rapid, pressured, loud speech, easily distracted, a lot of jokes, a lot of puns, a lot of sarcasm, complaining. They're very dramatic. They might burst out into song. They can have alterations in the relationship, such as multiple failed relationship, job loss, failure. They can be seen as overbearing. So they're over, right? They're overbearing. They're hypersexual. They're alienating. They're irritating. They're blaming. They're manipulating. They test the limits. And they can have altered activity or altered appearance. You can see pacing, flamboyant behavior, and they may forget to eat or bathe. It's not that they don't care to, like the major depressive patient. They're just so busy doing everything else, they don't have time. They just didn't even think about eating or bathing. Subjective behavior in our bipolar patients. You can see an alteration in their affect. They have the grandiosity, their rapid mood swings, elevation to irritability, happy to angry. Alterations in perception. These patients also can have some delusions and hallucinations. But again, once we get them under control, that typically goes away, as opposed to our schizophrenic patients. They think the etiology of bipolar disorder can be a combination of genetics, psychological, environment, and biological, just like all the others. 85% of patients with bipolar also have a comorbid mental health disorder. These include borderline personality disorders, ADD or ADHD, GAD, you can look that up, it's in your book, I just shortened it, panic disorders, PTSD, substance abuse. Substance abuse could be a cause of their bipolar, but it can also be a symptom of their bipolar. Maybe they're self-medicating, right? But typically patients with bipolar disorder also have something else going on. So the treatment goal of someone with bipolar disorder, these goals include, if they are having manic episodes, getting that under control. We want to try to prevent relapses from happening, and we want to help them try to return to a prior level of functioning. Again, this is not usually capable. These goals are not capable. These are not our goals with schizophrenia, right? Yeah, we want to get the signs and symptoms of schizophrenia under control, but they're probably going to relapse and they may never return to their prior level of functioning. People with bipolar disorder can definitely be managed to return to a prior level of functioning. Medications used to treat our bipolar clients. First line gold standard is lithium. It's a mood stabilizer. It's discussed on page 172 through 178. It inhibits the release of norepinephrine, serotonin, and dopamine. There's a very narrow therapeutic index. I want you to know this number. It's just something you're going to have to memorize, because I bet you anything on boards somewhere you will see a lithium toxicity level. So this is just one of those things, kind of memorize however you need to do it, whatever works for you. Lithium toxicity happens at a level greater than 1.5 MEQs per liter. A typical dose is weight-based. It can be weight-based, can be based on have they taken it before, some other things, but I mean it can range anywhere from 400 milligrams to 1200 milligrams in a day. Typical side effects of lithium that we might see, which are mild and should subside over time, so we can educate our clients to know you may have some nausea, some dry mouth, and diarrhea. That should go away over time. What we want to know about, if there's vomiting, if they have severe tremors, right? A little bit of shakiness may not be considered severe. But if they can't control the jerking of their head, they're probably at a toxic level. We're going to draw some labs. They're sedated. They're super weak. They have some vertigo. Or they have giddiness, tinnitus, blurred vision. All of those things is because lithium inhibits the release of the norepinephrine, serotonin, and dopamine. And those are toxic side effects that we've got to know about. Severe toxic side effects of lithium, if they're super, super toxic, they can die. Okay, so we're really going to monitor these clients. They can have a seizure, they can go into a coma, and they can die. Also, clients can be given anticonvulsants that help them with their bipolar, and those are listed here. You're probably familiar with a lot of them. And then there's some antipsychotics listed there that we might use as well to treat some of the signs and symptoms that they may be exhibiting. Lithium is absorbed in the GI tract. It's excreted by the kidneys. It really, a lot of it remains unchanged in the body. It's not metabolized. 95% of it remains unchanged. It's about 50-50 in how it treats mania, so you got a 50-50 shot if a patient's having bipolar and mania of using this to control the manic episodes. So if you have a client that's starting lithium, you need to educate them on those expected side effects. Again, let them know the mild side effects. Those are some things that we would not stop the medication for. They are to be expected, and we hope that they go away. If you have a client who exhibits the toxic or the severe side effects, they need to know what those are, because they need to let us know. Educate your client regarding the toxic side effects. They need to be encouraged to take their lithium with food because it can cause nausea. That is an expected side effect. So to decrease the risk of nausea, they should take it with food. It also can make them have dry mouth, so they need to have adequate fluid intake. And edema is common with this. That is not a toxic side effect of lithium. We hope again that it goes away. They can elevate their legs throughout the day to help with that dependent edema. And then they need a consistent sodium intake. There's a correlation there between the sodium intake. They don't want to go really, really high, and they don't want to go really, really low. Sometimes when patients are put on lithium, they'll be put on a sodium restricted diet in the hospital, and then asked to continue that when they go out. Just know though that sodium and lithium kind of work together. So in medical management for our clients with bipolar and mania, adherence to their medication regimen is a major issue. A lot of these clients, the medication helps them feel better. They stop taking it, and then they're right back where they started from. So we really want to encourage our patients not to stop, and especially not to stop any medication that has impacts on their brain chemistry. We don't want them to stop that cold turkey. In these clients, the use of antidepressants, remember these are not our depressed clients, these are our bipolar clients, bipolar 1, bipolar 2, especially bipolar patients with mania, bipolar 1. Antidepressant use is controversial. It actually has been shown that it could possibly trigger mania. So you don't see a lot of bipolar patients on antidepressants. Electric shock therapy or benzodiazepines may help treatment-resistant mania. Really kind of depends on the patient. Milieu management for our patients who have bipolar disorder Remember, always, always, with all of our clients, number one, safety. Avoid harming self and others. That's our number one concern for these patients. We need to have a consistency among the staff, reduce the environmental stimuli, deal with our clients who are escalating to try to keep them from continuing up the escalation, reinforce appropriate hygiene and dress and expectations, reinforce the need for nutrition and sleep. These patients need a routine. Bipolar patients, kind of, especially with mania, tend to be all over the place. So a daily routine can really help these clients. And then use of a mood disorder rating scale. Again, tools are great to help you kind of check in with your clients. We use them for pain. You can use them for depression and other things as well. How you doing today? On a scale of 0 to 10, 10 being the worst depressed you've ever, or I'm sorry, not depressed, but the worst you've ever felt with this disorder, 0 being before you were diagnosed, you never had any problems. How are we doing today? So tools like scales can be useful in distinguishing severity. Sometimes it's the patient that gives you the information. Sometimes it's your own self-assessment on how manic is a patient today as opposed to yesterday, and it helps you build a pattern for your assessment and decision making. All right, guys, that was a lot of slides. It was a lot of talking for me, and I know it's a lot of listening and information for you. You're going to do great. Keep your nose to the grindstone. It'll be so worth it. Again, a lot of this stuff is the same on a lot of the slides. Just know the differences in the different diagnoses. If you're the nurse, can you tell this patient from that patient, this diagnosis from that diagnosis? And then what meds are we using for each of these diagnoses, and what are the main concerns that you would need to educate your client for, or that you're going to need to assess them for? Know how long it takes some of these meds to work and kick in. Okay? All right. Have a great day, and I'll see you later. Bye-bye.